All right, thank you very much for having me. And I was instructed by Mark to talk about two things. One is what we are doing with immunotherapy for neuroblastoma at Memorial. As many of you know, that has been the focus of our immunotherapeutic endeavors for the last 3 decades. And so I wanted to provide you with an update of what's going on. And then this very provocative question, which was asked by Mark, not me. But I want to just discuss some of my views on this. So I want you to make some broad statements, and then I can take some questions about details. And I want you to put the immunotherapy in context, what it is beneficial for, what it's not beneficial for, and what we hope it may be beneficial for. Immunotherapy for patients in first remission. How can we harness immunotherapy to treat neuroblastoma, where we are with our current studies in Memorial, and why are we considering new therapies for immunotherapy, new options for immunotherapy, and where those are going, and then something maybe about combining immunotherapy to benefit our patients. So these are some broad, very broad statements, and there's probably some consensus about most of these, is that Dr. Yu has shown that anti-GD2 monoclonal antibodies are beneficial in preventing recurrence after first remission. And we have been using 3F8 for the last 3 decades, and our data now seem to be coming together. We also know that immunotherapy is not very effective as it stands now for soft tissue disease and for large disease burden. And that consensus is from all the antibody and vaccine studies that have been tested in patients so far. What is the role of cell-mediated immunotherapy? We don't know yet, but there are exciting studies going on both at MSK and outside. And one strategy that we have used at Memorial is that antibody therapy has been part of the strategy for relapsed neuroblastoma, where we've treated patients with some other therapies and tried to reduce the disease burden as much as possible after relapse, and then consolidated their remission with immunotherapy. And finally, as many of you know, radiolabeled antibodies have been part of a regimen that has been very effective in treating patients with CNS relapse, and that thankfully is a very rare event in neuroblastoma. But we do have a very effective and successful approach to those patients, and I'm going to just touch upon that in one slide. So we want to use all the possible options for immunotherapy at our disposal. So, for example, antibodies. Antibodies up in the first panel can be used to target macrophages, complement, and neutrophils, and those can all destroy neuroblastoma cells. We can construct specific antibodies. So a bispecific antibody is an antibody which has basically 2 arms. One sticks to an antigen on neuroblastoma, and the other recruits cells or sticks to cells. Or you can insert a specific receptor called the chimeric antigen receptor. Thanks, Danny. Or we can use a specific receptor which has been used in studies at Baylor, where you can introduce a receptor into a T cell that recognizes neuroblastoma, and that kills neuroblastoma. What we've done, I'll show you a slide about that, is to make a bispecific antibody and stick it on to a cell, T cell, to try and recruit it so that it can attack neuroblastoma. And then so that's about cells, or you can use natural killer cells, as we've been using over the last 3 or 4 years. And finally, we want to train the body's own immune system using DNA vaccines, or vaccines, in this case, glycolipid vaccines. So we want to use all components of the immune system to provide effective immunotherapy for neuroblastoma. And antibody therapy has been around for the longest. In our case, we use the antibody 3F8, which binds to the glycolipid antigen GD2, which Dr. Loader talked about. And GD2 sticks onto the neuroblastoma cells. It recruits natural killer cells, neutrophils, and macrophages, and it deposits complement, and all these things work together to kill neuroblastoma cells. So that's how antibodies work. They're not very useful to attract T cells because T cells require an HLA molecule which is not present on most neuroblastoma cells. And you've seen these slides before. Dr. Yu showed that giving chimeric 1418 antibody has improved event-free and overall survival for patients in first remission. And over the decades, we've been using 3F8 or 3F8 plus GM-CSF, either IV or subcutaneously, and have shown that the outcome for patients in first remission has improved over the decades. And we also have used radio-labeled antibodies, either 3F8 or another antibody called 8H9, to treat patients who have CNS relapse. And thankfully, CNS relapse is a very rare event in neuroblastoma. Only about 8% of patients experience that. But using a multimodality therapy, including surgery, chemotherapy, craniospinal radiation, and radio-labeled antibody injected directly into the CSF, followed by maintenance treatment, we've been able to successfully treat most of our patients who had CNS relapses. And finally, patients who relapse in the CNS, and especially those who have single-site relapses, can be successfully salvaged. And so this is a group of patients we treated with chemotherapy and 3F8 in first remission, and about 55 to 56% of those patients were long-term survivors. Just worth pointing out that this is even 10 years, the curve is flattened out after 4 or 5 years. And not all of these patients succumb to their disease. So if the curve's been moved up from here to here, means that about 25% of patients were salvaged with some sort of treatment for relapsed neuroblastoma and are now cured of their neuroblastoma. So the bottom line here is that there is a group of patients who relapse who can be salvaged. And linking to that is surveillance testing. The importance of detecting early recurrence may help salvage patients with a combination of standard and experimental agents. So that's where we are currently. So why should we look at new immunotherapies? We all know that anti-GD2 antibodies are associated with a lot of pain. This relapse rate, even though we've improved it from here to here, there's still this group of patients, 30% of patients who succumb to their disease. So that relapse rate is still unacceptable. We know that antibodies are not useful for high burden disease. So even though I say that 55% of our patients are cured with chemotherapy and immunotherapy, about 20% of patients never got to this point. That is, their disease was never, first remission could never be achieved in these patients. So we still are struggling against that problem. And finally, improving the survival from here to here is not acceptable. So we need better immunotherapy for patients who do achieve second remission. So these are the various reasons why we want to do more, why we want to produce or create new antibody therapies. And just as you heard a lot about personalized medicine and genomics and so on, there's also a new era that has been ushered in protein engineering. So when we wanted to make personalized antibodies, or we wanted to create antibodies 25 years ago, making each antibody was a mammoth task, which required many, it was exorbitant. But now protein engineering has become much, much more accessible and much more, much less expensive. So say we want to make an antibody. A classical antibody is this antibody. In the past, we could tag on radiation to it, so we could make a radioactive antibody, or we could add a drug to it. And this, again, is a new concept, which has been very successfully used for patients with Hodgkin's disease with an FDA-approved agent called brentuximab. So now you've got your antibody, you just engineer it to add a drug. So this is a much more by far an easier option now for engineering an antibody. Instead of giving IL-2 intravenously or subcutaneously, which is associated with toxicity, you can tag the IL-2 along the antibody itself with possibly less side effects. You can take a toxin, such as a Pseudomonas toxin or ricin, and then tag the toxin to the antibody. And this has been used both with some of the antibodies we've been making and with other antibodies against AML. And this was kind of the situation about 10 years ago. But over the last 10 years, the science has moved such that we can design a whole lot of other antibody constructs which potentially have much better immunotherapeutic effect. For example, we can make bispecific antibodies, and bispecific antibodies can recruit T cells, which is a type of cell we've never been able to harness before. We can plug antibodies onto a payload which has, for example, a drug or RNA or some other agent, and these antibodies can then take this drug to the right place. Or we can make a chimeric antigen receptor, that is, we make a receptor and plug it into a T cell and makes the T cell work more effectively. And so this has, over the last decade or so, allowed our group to kind of reinvent our approach to immunotherapy by making newer molecules, which we are testing now. The first molecule we made was humanized 3F8. And why did we do that? Because mouse antibody 3F8 made from mouse cells elicits an immune response in humans. So we want to make an antibody that mimics human antibodies as much as possible. This human antibody may have better effector function. It may have a longer half-life requiring fewer administrations. It may reduce allergic reactions because the closer an antibody is to a human construct, the less allergic reactions patients are going to experience. And we can engineer the antibody to reduce complement fixation and therefore reduce pain. So these were the reasons why we chose to humanize 3F8. And this slide basically shows that with all this new technology, we were able to make, and this is just a partial table, many, many constructs. And we tested all these constructs, and we found that this antibody, humanized 3F8, has a very good anti-tumor effect. And the complement activation is only about 40% of the mouse. So theoretically, this antibody should be better than a mouse antibody. This is 217 times better in the test tube, and 19 times better using neutrophils, but only 0.4 times as much as effective in inducing complement activation. So it should be less painful and should be more effective. So we chose that antibody. And again, coming to the ease of technology, we can go through this whole process of making an antibody using GMP, that is, procedures which are acceptable to the FDA, both to make the antibody and then to manufacture large amounts of it, to do the quality assurance, to put it through IRB and FDA and get it to the patient in a much shorter period of time than we used to 10 years ago. So this whole process of making humanized 3F8 and starting the study really took us only 2 years, partly because the technology was effective, but also because of a lot of help from our patient groups, and in particular by the banding together of patients into a group called the Band of Parents. And this is a controversial concept, but we could call this venture philanthropy. And in this concept, and that is not unique to neuroblastoma, it's also been used for many, many other drugs, especially if anybody isn't keeping in touch with the current news about the drug for cystic fibrosis, where a parent group funded the production of a drug. And in this case, the Band of Parents raised money to make a drug. And there was a financial arrangement with the Band of Parents such that if this drug was commercialized, there would be some financial benefit to the Band of Parents. Now, this is very far from being commercialized, but this new concept of so-called venture philanthropy, I think, deserves to be explored at least, although the ethics of it and the practicality of it needs to be explored further. But what it allowed us to do was to make a drug which was independent of pharmaceutical industry, because as we all know, pharma is not terribly interested in rare pediatric tumors. We could produce it at a fraction of the cost required by pharmaceuticals because we didn't have any marketing to do. And theoretically, this could enhance portability of the drug, that is, allow other centers to use this drug, which we have not succeeded in the past with mouse 3F8. So the first study using humanized 3F8 was launched in, this is about to close in 2011. where we used antibody alone. And these are some bottom line points from these studies. We've seen much less pain and allergic side effects, but pain is not completely absent. Just to give you a background about how we do 3F8, even mouse 3F8, it's an outpatient procedure infused over half an hour, and we don't admit patients at all for it. So to measure how much less pain these patients experience, we use, as you heard before, not only pain scores, but how much rescues of pain medicine they received. And so far it seemed that we were able to escalate the dose to at least 3 times higher than the mouse antibody, although that may be comparing apples and oranges, but at least 3 times higher than the mouse antibody with much less pain. Then we've combined humanized 3F8 with IL-2, and we found that IL-2 is at least in preliminary data, has a negative effect on the pharmacokinetics and the biodistribution of 3F8. And this is in keeping with the similar data we've seen recently from the group from Dr. Leidenstein's group. At least we are not seeing a beneficial effect of IL-2, but this is an ongoing study, so I cannot vouch for that statement quite just yet. And the third study is combining humanized 3F8 with GM-CSF, and in this study we see that the toxicities are very similar to that of humanized 3F8 alone, and we are starting to see some anti-tumor response now at higher doses of humanized 3F8. Where are we going with humanized 3F8 in the future? This study, where we take a small amount of radioactivity, label it with humanized 3F8, and we inject it into patients, and we want to ask ourselves, where is the 3F8 going? How is it going to the disease? Because when we give antibody, we really have no way of knowing whether disease is being targeted with it unless the disease shrinks. But by giving a radioactive antibody it's like a scan, like a PET scan, we can calculate how much antibody is going to the tumor and to each organ, and perhaps that might help us with designing our 3F8 studies better, or attaching a much larger amount of radioactivity down the line for radioimmunotherapy. The phase 2 study this study was approved by the FDA just last week, and so hopefully we'll be able to start accruing patients on this study quite soon. We are going to launch a phase 2 study within the next 3 months using humanized 3F8 and GM-CSF. And then finally, there's a study of NK cells and 3F8. I'm going to touch upon that. So that's where we stand with the humanized 3F8. What are we developing? What else are we developing? One construct which is very near the clinic is using a bispecific antibody. And a bispecific antibody binds both to the neuroblastoma cell via GD2, but also binds to T cells. And this is a fully human form of antibody, so it should not create allergic reactions or rejection. And at least in the preclinical animal data and the test tube, we find this to be a very, very effective, much, much more effective drug than 3F8. And the hope is that this type of antibody may be useful for bulk disease and may be useful even for soft tissue disease, because this is a much smaller molecule than a regular antibody. And there is a drug, as some of you may know, which is on the verge of being approved by the FDA, called blinatumomab, where this type of antibody is being used for leukemia, which targets an antigen called CD19. And there are other things we've engineered such that it should not have the pain effects and cytokine storm which the blinatumomab has seen. And we hope to be able to accrue patients on this trial late next year. And for some reason, this picture is a bit cut off, but instead of using the bispecific antibody by itself, we can modify this bispecific antibody such that we can then target radiation to the tumor, basically by taking a radioactive metal such as yttrium and tagging it to the antibody in a much better way than we have done so before. And this is still in clinical testing, and if the preclinical testing goes well, I think it's beyond preclinical testing. If the bulk antibody can be produced, that should go into trial by 2016. Besides GD2, which is the glycolipid antigen you've heard before, we are also targeting another antigen called B7H3 with 8H9, which many patients have already received for CNS neuroblastoma. We are making the humanized form of 8H9, and we are also making an antibody against an antigen called L1-CAM, which other groups have also looked at. And besides these typical classical antibodies, we are also trying to make a new potentiating antibody cytokine complex called IL-15. To switch gears a little bit about cell-mediated therapies. Where are we with cell-mediated therapies right now? We've almost completed a phase 1 study where we took NK cells, which are natural killer cells from parents, and injected those into our patients with 3F8, because patients' NK cells don't recognize the neuroblastoma and therefore are ineffective against the patient's neuroblastoma. But it is possible that NK cells which are at least 50% different from the patient's neuroblastoma can have an anti-neuroblastoma effect. So we've treated 24 patients so far. We have not seen any graft versus host disease. That means these NK cells, they are short-lasting. They don't replace the patient's immune system. So we have to give multiple infusions for this to be effective. But we are seeing some signs of signal. We are seeing some biological effect that if the patients and the parents have a mismatch, that is, there is a difference in the repertoire of receptors on the patient's neuroblastoma and the donor's NK cells, we seem to be getting better responses. And we are now going to combine these NK cells with humanized 3F8, and that phase 1 study is going to be opening early next year. And finally, vaccines. Many of you know that we've completed a phase 1 study using an anti-GD2 vaccine, where we take GD2, and as you've heard, GD2 is not immunogenic. It does not lead to immune responses in patients because it's a sugar or a fat. But when we conjugate it to certain molecules, one of them is called KLH, made from shellfish. Another one is an analog of a tree bark product, OP821, and combined with beta-glucan, we found that patients in second remission have a progression-free survival of about 78%, which is, all of our patients, 12 out of 15 patients, are now more than 3 years out. But there are caveats to this. All these patients were selected in second remission. That means they relapsed, we gave them chemotherapy, we got them back into remission, and then we treated them with vaccine. So there is a selection bias here. We need to take consecutive patients and ask the question, and that's what we are studying now. So this initial group of 15 patients we published. That trial was completed 2 years ago. We waited for 2 years. We didn't see any side effects, and we've launched a phase 2 study. And this is the vaccine in which I know NCCA is trying to take forward in the UK. But these data, at least in the first cohort of patients, hold true. And the second cohort of patients, they're not too dissimilar from this data, although I don't have those data to share with you. Now, we do have opportunities to combine immunotherapy. We've already done this. For example, a strategy for second remission is to first give patients antibody, then followed by vaccine, so that we can use both immunotherapeutic modalities for our patients. We can do consecutive therapy. We can give cells, follow that by antibody, like we are doing with NK cells. We can combine these chimeric structures where we take T cells, we arm them, or we make chimeric antigen receptor cells. And finally, there's a lot of work going on in the adult world using modifying T cell checkpoints with ipilimumab or PD-1 or PD-L1 antibodies, although these antibodies are not going to be useful for neuroblastoma because they all work through HLA mechanism. However, we are looking into using anti-KIR antibodies, that is blocking the inhibitory receptors on NK cells. So these are various opportunities we have, and the adult world has already started combining antibodies and cells and antibodies together. So that's the first part of my talk, and then the next 5 to 10 minutes, I'm going to talk about this question which I was asked to talk about. Will chemotherapy always be part of the treatment protocol for stage 4 neuroblastoma? And I don't need to tell you why we are so concerned about chemotherapy, because in the acute phases, patients can die of high-dose chemotherapy. They can have organ damage. In the chronic setting, we have our patients with hearing loss, with growth failure, impaired puberty and gonadal function, and secondary malignancies, amongst a list of possible side effects. So we want to reduce or eliminate chemotherapy as much as we can. Can we do it? At Memorial, we have, in a nutshell, not been treating patients with low stage MYC non-amplified disease with any chemotherapy at all. And as the rest of the world does, patients less than 18 months at diagnosis, we've been reducing the dose of chemotherapy as much as possible. But for MYC amplified stage 3 patients and stage 4 patients, we have been giving high-dose chemotherapy induction. Up till now, 2100 centigrade radiation, although we now have a study where that has been reduced to 1800 centigrade, which is a prospective study which is already halfway through. We have not been doing transplant. And instead of transplant, we've been consolidating remission with 3F8 alone. But this still doesn't take away the side effects of all the dose-intensive chemotherapy. So where can we reduce chemotherapy? In what settings? Or eliminate chemo? Clearly, this is more or less a consensus of what most people would agree. Stage 4S disease, we don't need to do chemotherapy in most patients. Those rare patients in whom neuroblastoma was discovered very early on in life, antenatally or in the first month of life, we can almost always just observe those patients. In intermediate risk group patients who don't completely respond to chemotherapy, we've not been going after the residual disease. We've been monitoring them, and by and large, patients have not progressed. For patients with stage 3 or below, we have not been doing chemotherapy and just doing surgery alone. And over the years, we've tried to attempt to reduce chemotherapy cycles for stage 4 neuroblastoma less than 18 months at diagnosis. And our induction protocol right now uses 5 cycles of high-dose chemotherapy, whereas 15 years ago, we had patients receiving 7 cycles of chemotherapy. Nevertheless, many of the side effects which I mentioned, we still worry about and are real problems. So why is it currently difficult to reduce or eliminate chemotherapy? One reason why we need to do chemotherapy is if the patient has a large tumor which the surgeon cannot resect or which is potentially lethal to resect. We need chemotherapy to allow the surgeon's surgical planes to be improved and surgery to be more successful. We know that our current immunotherapy regimens are not very effective for soft tissue disease. We've heard a lot about genomics and genomic aberrations and personalized medicine, but the fact of the matter is that at diagnosis, the genome is bare. That is, apart from MYC and 8% of patients with ALK mutations, we really haven't found any targets at diagnosis. So to hope that using current technology, that's why I've bolded this, to find targets which we can dial in a drug, say we find a target and we use exactly that drug, that's not realistic at diagnosis. Although at relapse, we see many more genomic aberrations. Whether these genomic aberrations at relapse are targetable or not, the jury remains out. For example, we've tested about 100 relapse soft tissue samples using the state-of-the-art genomic testing, and we see quite a lot of genomic aberrations. But most of the genomic aberrations we see are not we have not been successful in targeting. We have about 3 out of these 40 patients who I feel this approach has benefited. But by and large, we have not been able to make a whole lot of sense, at least with the current technology, in finding exactly the right treatment for that patient. Stable disease can be achieved with a lot of drugs, including immunotherapy, and many of these agents we see, which we use, often lead to stable disease. But in melanoma, for example, BRAF mutations, which are targeted by 2 drugs, can lead to a significant cure in many patients, even without chemotherapy. And that dream is yet to be realized for neuroblastoma patients. So we have to keep working on it, and people like Giselle and John are leading the way in trying to address this question. Finally, what do we know so far on ALK and MYC-N? We know that the currently available inhibitors for ALK are not very effective for neuroblastoma. They're very effective for lung cancer. And designing inhibitors for MYC-N has been a very big challenge. And so far, whatever we have available is not very useful. So these are some of the obstacles we face when we try to think about eliminating chemotherapy or reducing chemotherapy. However, I strongly think that we should rethink the role of transplant in this era where we have very aggressive induction chemotherapy and we have antibody therapy, which is very accessible to all of us now. So when we looked at our groups of patients who received 3F8, we saw that patients who got 3F8 after transplant versus not going through transplant, there was no difference in progression-free survival or overall survival. However, this was not a randomized study, and it was a single institution study, so these caveats have to be kept in mind. That is, this was a selected group of patients. However, in June this year, the COG group updated their data on their seminal study where they treated half the patients with transplant and the other half without transplant. And when it was first published in 1999, there was a clear difference in the survival for those patients. But when they reanalyzed the data 5 years later, their overall survival was not better. And this was in an era where all the patients did not get very good radiotherapy, they did not get immunotherapy, and the induction chemotherapy was relatively low. So despite these factors stacking the deck in favor of transplant, the overall survival was still not significantly better. So I think we have to ask ourselves, rethink whether we should be doing transplant at all for these patients. The dogma today is CEM versus Bumel, but we do need to at least our group feels that we need to take a step back, not only based on our data, but on the updated analysis from the COG data, whether we should be doing transplant at all in the modern era, where we have more tools at our disposal. We tend to do better surveillance studies for our patients, so we can detect relapse earlier. We have better therapies available for relapse patients, and we have immunotherapy available now for all our patients. So I think at least this is a question worth debating and worth considering, because transplant is not really a walk in the park. And finally, I'd like to thank all my collaborators, which is a big group of people who care for patients with neuroblastoma at Memorial. I'll take questions. Thank you.